Hello everyone, and this is the daily quiz series in the run-up to NEETPG 2025. Today I'll be tackling some questions from renal and GI tract. So let's look at the first question. Now this says, a patient with severe dehydration shows a decrease in GFR. Which of the following mechanisms is responsible? Is it an decreased sympathetic tone? No, this is going to be in a patient with dehydration, the sympathetic tone will increase. So this is not the answer. Is it an increased afferent arteriolar pressure? Now here is a patient of dehydration, hypovolemia, hypotension. We expect that the afferent arteriolar pressure will decrease, not increase. Will there be an increased renal perfusion? In fact, quite the opposite. It is going to be a decreased renal perfusion. So a decreased renal plasma flow and an increased sympathetic tone, this is going to be the answer. And because there is a decreased renal plasma flow and a increased sympathetic tone, this in fact causes a decrease in the glomerular capillary hydrostatic pressure. Please remember, hydrostatic pressure is the pressure due to a column of liquid. Less flow into the glomerular capillaries. Why is there less flow? Because there is a hypovolemia, dehydration and hypovolemia. So less flow into the glomerular capillaries means a less hydrostatic pressure, and less hydrostatic pressure means less will be the filtration or less will be the GFR. What about the sympathetic tone? Because of dehydration and hypovolemia and hypotension, there is an increased sympathetic discharge. Now, increased sympathetic discharge causes a renal afferent arteriolar constriction. And if there is an afferent arteriolar constriction, it will decrease the flow into the glomerular capillaries. There is a decreased glomerular capillary flow. Please remember, smaller the radius of a vessel, less will be the flow. Flow is directly proportional to the fourth power of radius. Less the radius, less will be the flow. Less the flow, less will be the hydrostatic pressure. And hydrostatic pressure is the most important pressure which is responsible for filtration in the glomerular capillaries. So less hydrostatic pressure, less will be the GFR. So answer here is D. Which of the following has the highest renal clearance? So 2-3 important points before we deal with this question. What is clearance? How do you define clearance? Clearance of a substance is volume of plasma cleared of that substance or free of that substance. Cleared of that substance or free of that substance in unit time. And the unit for clearance is ml per minute, volume of plasma free of that substance in unit time. And the formula for clearance is, clearance of any substance X is urinary concentration of X into rate of urine flow divided by the plasma concentration of X, UV by P. Now, remember, concentration is always per unit volume. So, urinary concentration is milligram per ml into urine flow rate. Rate is always per unit time. So urine flow rate will be ml per minute divided by the plasma concentration, which is milligram per ml. Both of these will cancel each other out. And finally, the unit for clearance will be ml per minute. Remember, the inulin clearance is equal to the GFR. Why is the inulin clearance equal to GFR? Because inulin is a substance which is freely filtered, not reabsorbed, not secreted. So that means the rate at which it is cleared from the plasma is the rate at which it is being filtered, because it is only removed by the process of filtration. So rate of clearance of inulin will be equal to the glomerular filtration rate. Now, any substance which is reabsorbed will have a clearance less than the clearance of inulin. Why less? Because if the substance is being reabsorbed, that means it is re-entering the plasma, right? And if it re-enters the plasma, then the volume of plasma free of that substance in unit time now reduces, filtered, and re-enters into the plasma. So the volume of plasma being free of that substance in unit time will now be less than the clearance of inulin. So any substance which is reabsorbed will have a clearance less than the clearance of inulin. And similarly, any substance which is secreted, that means it now from the plasma, it enters into the tubule. If it is secreted, then the volume of plasma cleared of that substance in unit time will now increase. It will be more than the clearance of inulin. So all reabsorbed substances have clearance less than the clearance of inulin, such as glucose and urea. These are both reabsorbed. All secreted substances will have a clearance which is more than the clearance of inulin. Now, creatinine is one substance which is freely filtered and slightly secreted. Because of that slight secretion, its clearance becomes more than the clearance of inulin. But please remember, it's only slightly more than the clearance of inulin. In fact, sometimes we also take the clearance of creatinine for estimation of GFR. It's almost equal to the clearance of inulin, right? We take the clearance of creatinine equal to that, to the GFR. Yes, but like I said, creatinine clearance is actually slightly more than the clearance of inulin. So this is answer to this question is D, creatinine. A marathon runner is running the race on a hot, humid day. He has profuse sweating, very high ADH levels. Maximum water reabsorption in the presence of high ADH is from which of the following? Now, when I look at the water reabsorption in different segments of the nephron, remember the GFR is 125 ml per minute or 180 liters per day. That is a huge amount of filtration. 180 liters is like 6 buckets of water. Each bucket of water is 30 liters. So 6 buckets of water is the kind of filtration that happens in our kidneys every day. But the urine output is just 1 to 1.5 liters per day. So that means almost 99.5% of the water is being reabsorbed. Right? So the reabsorption, 2/3 of the water reabsorption will occur in the PCT. That means out of 180 liters, 120 liters is being absorbed in the PCT. And this is known as obligatory. That means this will happen whether ADH is present or not present. Right? So this is obligatory. After that, the water reabsorption occurs in the descending thin segment, about 15 to 20%. Then facultative reabsorption of water occurs in the collecting duct. This is under the control of ADH, and this is about 13 to 15% or 23 to 27 liters. Right? So that means ADH is actually controlling only about 13 to 15% of the water absorption. 2/3 of the water absorption is occurring independent of ADH, and that is obligatory. So in this question, by saying that there is a very high ADH, it is only meant to confuse you. Maximum water reabsorption will still be from the PCT, that is 66%. ADH can control only about 13 to 15% of water absorption in the collecting duct, and that is facultative. In peristalsis, which of the following neurotransmitters is secreted anterograde to the bolus of food? So if this is a bolus of food which is present, when food is present in the small intestine, it will stimulate the sensory neurons. Sensory neurons will secrete serotonin. And these will act on the local myenteric plexus neurons. Now, these local myenteric plexus neurons, behind the food, there will be a ring of contraction. So the myenteric plexus neurons behind the foot will release neurotransmitters which cause a smooth muscle contraction. So this is called retrograde or ORAD. There is going to be release of substance P and acetylcholine, both of which cause a ring of contraction behind the foot. And in front of the foot, the local neurons will now secrete smooth muscle relaxants such as nitric oxide and VIP. This is called anterograde or caudad. What is ORAD and caudad? ORAD towards the oral cavity, caudad towards the anal orifice. So anterograde or caudad, nitric oxide and VIP, these are smooth muscle relaxants. So they produce a relaxation in front of the foot. So answer to this question now becomes pretty simple. This is going to be D or VIP. Serotonin secreted by sensory nerves, substance P and acetylcholine are released behind the foot to produce a ring of contraction, and because of this, foot is going to be propelled forwards. It's going to be pushed forwards. Peristalsis results in a forward propulsion of foot. Which of the following causes a prolongation of the gastric emptying time in response to an acidic and hyperosmolar gastric chime in the duodenum? Now, whenever there is an acidic gastric chime or a hyperosmolar chime in the duodenum, it causes a decrease in the gastric motility and prolongs the gastric emptying time. This reflex is called the enterogastric reflex. Now, this reflex is extremely important in the sense that acidic chime, if it enters into the duodenum does not have the same kind of a protective mechanism like the stomach. So it's very important that the gastric emptying time gets prolonged so that the acidity of the gastric chime is neutralized by the alkaline intestinal secretions. Now, in the enterogastric reflex, what are the stimuli? The first one, of course, is a duodenal distension, presence of food in the duodenum itself. Then it also depends upon the type of food. A food rich in fats, rich in proteins will cause a greater inhibition of gastric motility as compared to a food rich in carbohydrates. Again, a very common experience. The day you have some desi ghee parathas or a food which is rich in fats, maybe bhatura or something, or puris, you have that sense of fullness. The gastric emptying time gets prolonged. Then it also depends upon the acidity of the gastric chime. More acidic the gastric chime, less will be the gastric motility, prolonged gastric emptying time. It also depends upon the osmolality of the gastric chime. Ideally, the gastric chime should be isotonic. Now, there are osmoreceptors present even in the duodenal mucosa, and this will detect if the gastric chime is hypo or hyperosmolar. Either way, it will cause a decrease in gastric motility and prolong the gastric emptying time. So this is your enterogastric reflex. What is gastrocolic reflex? When food is present in the stomach, defecation. This reflex is very prominent in infants. The moment you give a feed to a small baby, passes stools. This reflex is, of course, abolished in adults. Gastroileal, food in stomach, relaxation of the ileocecal sphincter. And defecation reflex, of course, we all know. So the answer to this question is C, enterogastric reflex. Tubuloglomerular feedback is for regulation of which of the following? Now, remember that between a mean arterial pressure of 90 and 200 millimeters of mercury, GFR is constant. And there are various mechanisms for maintaining the GFR constant? Number one, there is something known as the myogenic mechanism of autoregulation of GFR. Number two is the tubuloglomerular feedback. And number three is glomerular-tubular balance. So out of these, the best answer is going to be for autoregulation of GFR. Let's have a look at the next question. An elderly patient with type 2 diabetes mellitus presents with a fasting blood glucose of 250 to 40 milligrams per deciliter. Urine analysis reveals the presence of glucose in the urine. Which of the following is the best explanation for the glucosuria, the presence of glucose in urine? Is it because sodium glucose transporters have been down-regulated? No. Or is it because the filtered load of glucose has exceeded the transport maxima for glucose absorption in the PCT? Now remember, the glucose absorption in the PCT is with the help of sodium glucose cotransport, which is a protein. And whenever there is a protein which is involved, there will be a transport maxima because carrier proteins tend to get saturated. So there is a transport maxima which is involved. There is something called TMG, transport maxima for glucose. How much is that? In males, this is 375 milligrams per minute, and in females, this is 300 milligrams per minute. Please remember, this is a per minute value. That is because it is a rate. Transport maximum rate of absorption of glucose. And why is it a maximum rate? Because the protein tends to get saturated. So in diabetes, when there is increased filtered load of glucose, yes, how do you calculate the filtered load of any substance? Filtration rate of filtered load is GFR into the plasma glucose. So more the plasma glucose, more will be the filtered rate of glucose. More glucose in the PCT. Now, because it is going to exceed the transport maxima, some glucose will be lost in the urine, resulting in glucosuria. So filtered load of glucose has exceeded the transport maxima for glucose absorption in PCT. Renal threshold for glucose reabsorption is increased due to chronic hyperglycemia? No. Renal threshold is actually, this is the plasma concentration beyond which glucose begins to appear in the urine. So this remains constant. This does not change. So this is not the answer. Loop of Henle has impaired sodium glucose cotransport. Loop of Henle does not have any sodium glucose cotransporters. So this is also not the answer. Answer is B. ADH increases insertion of which of the following aquaporins in the luminal membrane of the collecting duct cells? Now, we've discussed water reabsorption in different segments. Aquaporin 1 is responsible for water reabsorption in PCT and the descending thin segment, but it is aquaporin 2 which is responsible for water reabsorption in the collecting duct. ADH will increase the insertion of aquaporin 2 on the luminal membrane. Aquaporin 3 and 4 are present on the basolateral membrane of the collecting duct cells. ADH does not have any effect on aquaporins 3 and 4. It affects only aquaporin 2. What is the receptor for ADH on the collecting duct cells? V2 epithelial receptor. Second messenger is cyclic AMP. So answer is B, aquaporin 2. A 40-year-old woman is injected secretin intravenously. Which of the following physiological responses will be seen in the woman? Increased gastric acid secretion? No. A decreased gastric acid secretion, in fact. Increased gallbladder contraction. Gallbladder contraction is done by CCK. Increased secretion of an enzyme-rich pancreatic secretion, also by CCK. Does it increase the secretion of bicarbonate in the pancreatic secretion? Yes, this is primarily responsible for a highly alkaline pancreatic secretion. The pH of the pancreatic juice can be as high as 8.8. So answer here is D. Clearance of para-aminohippuric acid measures which of the following? Is it actual renal plasma flow, effective renal plasma flow, actual renal blood flow, or effective renal plasma flow? Now, clearance of para-aminohippuric acid is very high because para-aminohippuric acid is freely filtered and completely secreted in the PCT itself. So, the clearance of para-aminohippuric acid measures the renal plasma flow. We've discussed a little while earlier that clearance of inulin measures the GFR because inulin is a substance which is freely filtered, not reabsorbed, not secreted. Para-aminohippuric acid, on the other hand, is completely secreted. So, the rate at which para-aminohippuric acid is removed from the plasma is the rate at which it enters into the kidney. So it measures the renal plasma flow. Now there are two terms over here, the actual or the effective. Now clearance of para-aminohippuric acid actually measures the effective renal plasma flow. Why effective? Because para-aminohippuric acid has an extraction ratio. Now what is extraction ratio? Now extraction ratio is, this is the arterial concentration minus the venous concentration divided by the arterial concentration. So that means if I look at the kidney here, this, supposing I have para-aminohippuric acid in low concentration, let's say arbitrarily, if I say it's 100 in the renal artery, right? Please remember, para-aminohippuric acid only in a low concentration is freely filtered and completely secreted, not in a high concentration. If para-aminohippuric acid is in a high concentration, it is incompletely secreted. So we are talking about para-aminohippuric acid in a low concentration. Yes. What is low concentration? That means it has to be less than 20 milligrams per deciliter. That is low concentration. So let's say take arbitrary, let's take it as 100. Now if it is freely filtered and completely secreted, that means I will have 0 in the renal vein and 100 will be present in the urine. This is what I mean by freely filtered and completely secreted and why it measures the renal plasma flow. But actually what happens is, instead of getting 100 in the urine, I get 90 in the urine and 10 in the renal vein. So that means, what is the extraction ratio? 100 minus 10 divided by 100, which is 90 divided by 100, which is 0.9. This is the extraction ratio for para-aminohippuric acid. Now, why does para-aminohippuric acid have an extraction ratio? Now, this is also very interesting that when I inject para-aminohippuric acid into the renal artery, yes, it is in low concentration. Yes, it is going to be freely filtered and completely secreted. But the point remains that not 100% of the renal artery blood is participating in filtration. There is a small percentage of the renal artery blood which goes into the renal capsule, into the adipose tissue which surrounds the kidney. So this blood, the para-aminohippuric acid in this blood, will be returned into the renal vein. That is why it has an extraction ratio, because all of the renal artery blood is not participating in filtration. So therefore, if I actually want the actual renal plasma flow, what can I do? I can take the effective renal plasma flow and divide it by 0.9. I will get the actual. So clearance of para-aminohippuric acid, yes, gives us the renal plasma flow, but a little more detail, it gives us the effective renal plasma flow. Why does it give us the effective renal plasma flow? Because it has an extraction ratio. Why does it have an extraction ratio? Because 100% of the renal artery blood, or all of the renal artery blood, is not participating in filtration. Small part of the renal artery blood goes to other areas surrounding the kidney, the renal capsule, adipose tissue, and this is returned into the renal vein. That is why we say clearance of para-aminohippuric acid gives us effective renal plasma flow.